Before the surgeon touches you, he ties you down. That is the first thing that happens when your body goes on the table in medieval Europe, not the cutting, the binding. And by the end of this, you will understand exactly why that detail changes everything you thought you knew about how a body survives being opened by someone who has never seen the inside of a hospital. Picture the room, not a theater, not a clinic. A barber surgeon's back chamber, or a tent pitched at the edge of a battlefield still smelling of smoke, or a monastery courtyard where the monks have cleared a trestle table into the light. The year is somewhere in the 13th century. The tools are on a cloth beside you, wiped but not sterile, because the word sterile will not mean what it means for another 600 years. There are people in the room who are not there to help you. They are there to hold you. 2 men for the arms, 1 for the legs, sometimes a 4th across the chest if the procedure runs deep. Their job is not comfort. Their job is stillness, because the surgeon's work depends on a body that does not move, and your body, the moment it feels the first thing it feels, will want to move more than it has ever wanted anything. Guy de Chauliac understood this. He was a French physician working in Avignon in the mid-14th century, personal surgeon to 3 popes, and the author of Chirurgia Magna, finished around 1363, one of the most influential surgical texts the medieval world produced. He wrote about procedure with a precision that sounds almost modern, and a casualness about suffering that does not. He cataloged what the surgeon owed the patient in terms of preparation, correct positioning, proper tools. He said almost nothing about pain because pain was not a problem to be solved. It was a condition to be managed around. So here's what managing it looked like. If you were fortunate, and fortune in this context is a relative thing, someone gave you something before the cutting began. Wine was common, heavy enough to blur the edges without stopping the heart. Some practitioners had access to soporific sponges, cloth soaked in mixtures of opium, mandrake, hemlock, and henbane, then dried and wetted again near the patient's nose before the operation. The theory was that you would drift somewhere between sleep and waking. The reality was inconsistent. The dosing was guesswork. The plant concentrations varied by season, by soil, by how long the sponge had been sitting. Some patients went under, some did not, and the surgeon worked regardless. He did not wait for the waking to stop. He waited for the restraints to hold. Your body is positioned now. Flat if it is your abdomen, seated and braced against an assistant's chest if it is your skull, angled forward over a table edge if it is your back. The positioning matters because the surgeon is working by daylight through a single window or by the unsteady light of tallow candles, and he cannot move you once he starts. You have been prayed over. In a monastery setting, this was not optional and not merely ceremonial. It was part of the procedure. The church and the body were not separate territories in the medieval understanding, and the soul needed preparation for what the flesh was about to experience, just as the flesh did. The first thing the surgeon does to you is not always a cut. Sometimes it is pressure. A large abscess, infected and swollen hard under the skin, required lancing, and the physical fact of it was this. A pointed iron instrument, the tip heated or not, depending on the practitioner's preference, was pressed into the highest point of the swelling until the pressure gave. What came out was not blood alone. It was whatever the body had walled off inside itself, which could mean weeks of infection consolidated into a single release. The patient was held for this, not because the procedure was long, but because the body's instinct at that pressure is immediate and total. Every muscle you have fires at once, but abscesses were the minor work. The cases that required a table, an assistant on each limb, a surgeon who had read de Chauliac or had trained under someone who had, those cases were different in scale. Arrow extraction meant working blind in a wound channel that had already started closing around the shaft. The surgeon could not simply pulling tore muscle against the grain of the arrowhead, which was designed to resist exactly that motion. He had to probe first with a finger or a thin iron rod to feel the angle of the head, then work it back along its own path or widen the channel enough to bring it out differently. You felt all of it. The probe going in, the decision being made inside your body by someone else's hand. The widening. Trepanation was older than medieval medicine by thousands of years and still in practice throughout this period. The skull has no pain receptors in the bone itself, which sounds like mercy until you understand that the scalp must be cut and folded back before the instrument reaches bone at all, and that the scraping of a trephine across the skull while you are conscious produces a vibration that moves through the entire head and has nowhere to go. Surgeons use it for skull fractures, for what they understood as pressure on the brain, for seizures they attributed to trapped spirits or corrupted humors. The logic was wrong, in ways we can trace precisely. The practice, in cases of genuine epidural hemorrhage, occasionally worked by accident. So the table held a body. The assistants held the body still. The surgeon moved quickly because speed was not cruelty. Speed was the closest thing to kindness the procedure allowed. And here is where the real logic of medieval surgery begins to surface, in what came after the cutting, in the heat and the blood, and the brutal arithmetic of what the body can lose before the calculation no longer matters. The cutting stopped. That was not the end. That was the beginning of the part nobody in that room could fully control. After the surgeon stepped back, after the restraints came loose and the assistants lifted you off the table, your body entered the phase that killed more people than the blade ever did. Not immediately. The dying in medieval surgery was mostly slow. It announced itself through heat first, then swelling, then a change in the wound that the practitioners who surrounded you had a word for, but not a cure. The word was laudable, as in laudable pus, as in the white, thick suppuration that appeared in a wound 3 or 4 days after the surgery was considered by most medieval and ancient physicians to be evidence that the body was expelling its corruption correctly, that the healing was progressing. This was wrong in a way we can now measure precisely, because what laudable pus actually meant was that bacteria were proliferating in tissue that had no defense against them. But the wrongness had its own internal logic. The wounds that produced thick white discharge often did survive, because the body was fighting, because the patient was young enough or strong enough to fight, and because the human immune system is more stubborn than any pre-germ theory practitioner deserved credit for. The discharge and the survival appeared together often enough that the correlation became doctrine. That is not stupidity. That is pattern recognition without a microscope. But not everyone shared the doctrine, and here's where the reading gets strange. Theodoric of Lucca, writing in the 13th century in his Chirurgia, said something that sat badly with almost every contemporary who encountered it. He argued that pus was not laudable, that it was not a sign of healing but of contamination, that the correct treatment for a wound was to keep it clean, to use wine as a wash, to close it quickly, and to disturb it as little as possible rather than probing and reopening to encourage drainage. He cited his father, the surgeon Hugo of Lucca, as the source of this method, and he described outcomes that were, by his account, consistently cleaner and faster than the standard approach. The medieval surgical establishment largely rejected him. He was too far outside the humoral framework that organized everything else. But what Theodoric was describing, without any understanding of why it worked, was suppression of secondary infection. Wine contains alcohol. Alcohol at sufficient concentration does real damage to bacterial cell membranes. His reasoning was wrong. His results were better than his critics. Henri de Mondeville, a French surgeon working in the early 14th century who had studied anatomy in Bologna and lectured to the French royal court, pushed the same direction. He argued against excessive drainage, against the common practice of packing wounds with material that kept them open and introduced new contamination with every change of dressing. He was difficult, politically, to his contemporaries. He wrote with a sharpness about the incompetence around him that made him enemies. He was also right about more than the era's consensus gave him credit for. There were other things that worked for reasons no one in that room understood. Honey had been packed into wounds since antiquity and would have seemed to a modern microbiologist almost reasonable, because honey's low water content and hydrogen peroxide production create a genuinely hostile environment for bacterial growth. Willow bark preparations, used for fever management in various forms throughout the medieval period, contain salicin, which the body converts to salicylic acid, the chemical ancestor of aspirin. The fever it helped reduce was real. The mechanism was invisible to the person administering it. The effect was not imaginary. None of this made the room safe. Your body, after the surgery, faced a narrow corridor. Shock from blood loss. Fever that could climb fast enough to stop the heart before the wound had time to either heal or kill by infection. If bone had been cut and in major amputations, the saw moved through femur or tibia with the surgeon bracing his weight against the resistance. The hemorrhage risk was acute and immediate. Cauterization with heated iron was applied to large vessels, not because it was tolerable, but because it was the only thing that reliably stopped the bleeding, and the alternative was watching the patient empty out in minutes. The body's response to that much heat on open tissue was a pain beyond what most people who have not experienced it can model. The assistants knew to expect the full weight of a person trying to leave the table. The restraints held. The surgeon completed the seal. And then you waited. In a bed, in a monastery infirmary, in a corner of a campaign tent. Your body doing the actual work, the immune system grinding against whatever had entered the wound. The clotting mechanism trying to close what the saw had opened, the fever spiking and breaking and spiking again while the practitioners around you changed dressings, prayed, administered what they had, and watched. Most people survived minor procedures. Survival rates for major amputations were worse and varied enormously by setting, by surgeon, by whether the wound was clean before the first cut or already infected from an injury that had been left too long. The numbers are hard to extract cleanly from the historical record, but the surgeons who kept records knew what they knew. They had seen enough bodies on enough tables to understand, without the vocabulary to say it precisely, that speed mattered, that cleanliness improved outcomes, that some wounds they could not save from the beginning and some they could. The person who went on that table was not stupid for going. The surgeon who stood over them was not a brute for cutting. They were both inside the same problem, a body that could be opened faster than it could be understood, in a century that had mapped the stars more carefully than it had mapped the blood. Picture the room again, the binding, the tallow light, the surgeon's hands moving quickly because he knew, in the way that practitioners learn through repetition rather than theory, that every extra second the body was open was a second the body was losing something it could not replace. That knowledge, earned without instruments, written in the outcomes of 1,000 patients who either walked out or did not, was a form of science. Incomplete, often lethal in its blind spots, but built from observation and tested against the only laboratory available, which was the living body held still on the table in front of them. Your body is the same body that survived those tables, the same fever mechanism, the same clotting cascade, the same immune response that ground through infections the surgeons could not name and sometimes won anyway. What changed is not the body. What changed is how precisely we can now read what the body was already doing. The fear in that room was real. The endurance was real. And the thin, uncertain line between the two is where medicine, in every century, has always done its actual work. If what happens inside that room stays with you, follow the thread. The history of what people did to bodies before they understood them is also the history of how understanding, slowly and at enormous cost, was made.